Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. The cardiology seminars are brought to you by Triple N Media, and our YouTube channel has more than 200 cardiology related lectures. We welcome you to watch them. We also kindly request you to subscribe to our YouTube channel. The information provided here is for education and entertainment purposes only and is not a medical advice. If you want me to research on a particular topic, please leave comments and I will be happy to research the topic and produce a video. I also have Cardiology Rotations Manual, which has 175 pages of pertinent information needed to enhance your cardiology experience during your cardiology rotations. I will tell you how you can get a free copy of this book at the end of this presentation. The feature presentation, Jugular Venous Pulse and Pressure. So let us begin with the feature presentation. The jugular venous pressure and pulse are a very important part of a bedside diagnosis of various cardiac conditions. Now, with the advent of echocardiography and pulse Doppler, a lot of these things can be detected using the echocardiography, but nonetheless, simple observation of the jugular venous pulse can give us a lot of indication as to the underlying pathophysiology that is going on inside the chest with reference to the heart, lungs, and various implications of that. If you look at the jugular venous pulse, generally it is an undulating form of wave, whereas an arterial pulse is just spikes. The venous pulse, on the other hand, has like a wavy form. And let's try to understand what is causing this waveform. With the atrial contraction at the beginning of the cardiac cycle, the pressure inside the right atrium increases, which is transmitted to the internal jugular veins, resulting in a wave of the jugular venous pulse. As the right ventricular pressure increases and the tricuspid valve closes, it causes a little bump, which is known as the C wave. As the right atrium begins to relax, the chamber enlarges, causing a decrease in the right atrial pressure, creating an X descent. As the blood begins to move from the superior vena cava and the inferior vena cava into the right atrium, the pressure begins to rise, creating the V wave, which is related to the atrial filling. As the right atrial pressure increases beyond the right ventricular pressure, the tricuspid valve opens, that's resulting in a Y descent with the flow of blood from the atrium into the ventricle. That is the hemodynamic explanation of these various waves and dips we see. So basically we have the A, C, V waves, then we have the X and Y descent. It is important to understand when these waves and descents occur during a cardiac cycle. That could be a question or two on your board exams. If you look at it from the cardiac cycle point of view, the A wave occurs during the atrial systole or during ventricular diastole. During ventricular systole at the beginning, when the tricuspid valve closes as the right ventricular pressure increases, we have this C wave. This X descent is during ventricular systole. The V wave peak occurs during ventricular systole. Then the Y descent is during ventricular diastole. If we put the whole thing together, the EKG, the heart sounds, and the pressure loops, you can begin to understand as what is physiologically creating these waves. As the atria contract, we have the A wave, and as the tricuspid valve closes, we get the C wave, and then we have the X descent, then we have the V wave, which is followed by Y descent. Just as the hemodynamic changes we see on the left side, we see similar changes on the right side. So if you think about left heart failure, atrial contraction, elevated left atrial pressure, you can correlate that to the right side also. As you can see, the A wave occurs before the first heart sound, whereas the Y descent happens after the second heart sound. There is a slight delay between the atrial electrical activity and the mechanical activity creating the waveforms. The way we measure the jugular venous pressure is based on the concept that you place the patient in a 45-degree angle, then you identify the junction of the manubrium part of the sternum with the body of the sternum, and from there you identify the top of the waveform and measure the distance. If this is more than 3 centimeters, it is supposed to reflect elevated jugular venous pressure. This is how you would measure the jugular venous pressure. We talked about the waveform, which is the pulse, then this is the pressure. Here is the junction of the manubrium and the body of the sternum. You put the patient in 45-degree angle, then you get a horizontal line from the top of the venous pulse and see how many centimeters. This is close to 4 centimeters. Means there is slight increase in jugular venous pressure. Couple of things about where the jugular vein is located. Most people refer to the external jugular vein, but when we are talking about jugular venous pulse and pressure, it is with reference to the internal jugular vein, which is more in direct line with the right atrial pressure. So the jugular vein is located between the sternal and clavicular head of the sternocleidomastoid muscle. Again, to summarize, A wave is caused by the atrial contraction, and by the same token, when we have atrial fibrillation, we are not going to see the A wave. In conditions where the atrial activity is increased or right atrial pressure is increased, like in patients with tricuspid stenosis or patients with the pulmonary hypertension, then we may see significant A waves. The C wave is caused by the closure of the tricuspid valve here during the beginning of the ventricular systole. The CV descent is related to the relaxation of the right atrial chamber. The V wave is caused by the return of blood from the superior and the inferior vena cava, and the Y descent is caused by the blood entering the right ventricle during the ventricular filling phase before the atrial contraction begins. Kussmaul sign. You have heard about Kussmaul sign. It is very important to know what is Kussmaul sign. Definitely you may get a question on Kussmaul sign, especially if you are taking cardiology board exams. During normal inspiration, the jugular venous pressure drops by about 3 centimeters, but in patients with constrictive pericarditis, restrictive cardiomyopathy, right atrial tumors like myxoma, or ventricular tumors, right heart failure, and massive pulmonary emboli, because the heart cannot expand, we don't see that normal drop in the venous pressure. On the other hand, there could be a distension of the jugular veins during inspiration. How do we differentiate carotid pulse from jugular venous pulse? First of all, the carotid pulse is located medially. Carotid pulse is something we can feel. Jugular venous pulse is something we just see, because if you press here at the bottom of the neck, the jugular venous pulse or the waveforms can disappear. The arterial waveform is like this, whereas the venous is undulant, wavy. During inspiration, the venous pressure drops, whereas the carotid, you don't see any change. And it doesn't change with position also, the carotid pulse. The venous is double peaked, whereas the arterial is just one peak. Venous is better visible, whereas Carotid is better palpated. Here they made the word police. You can read through this one. So let's look at some of the pathological conditions where the venous waveform or the pressure may be increased or decreased. The jugular venous pressure can be increased in patients with pulmonary hypertension, heart failure, tricuspid stenosis, or right ventricular infarct. The A waves may be absent in the absence of atrial activity, which is in patients with atrial fibrillation. Sometimes we see prominent A waves in patients with tricuspid stenosis, pulmonary hypertension, complete heart block, or chronic obstructive pulmonary disease. Here are some of the conditions that we need to keep in mind when we are talking about elevated jugular venous pressure. Right heart failure, fluid overload, tricuspid valve dysfunction, namely tricuspid stenosis, pericardial effusion, constrictive pericarditis, tamponade, superior vena cava syndrome, and pulmonary hypertension. Here are some waveforms which may be given to you in an exam. Let's look at some very important ones. In patients with tricuspid regurgitation, you see a large V wave. That's something you really need to remember. Why do we see a large V wave? Just think about it. During tricuspid regurgitation, when the ventricle is contracting, just like we hear a holosystolic murmur, there is blood going from the right ventricle into the right atrium. When blood is rushing into the right atrium from the right ventricle and from the vena cavas, obviously you're going to see a big V wave. And in patients with restrictive heart disease, we can see a sharp X descent, whereas in patients with tricuspid stenosis, we see a prominent A wave. And similarly, in patients with complete heart block, when the atria contracts against a closed tricuspid valve, we can see these big A waves known as cannon A wave. Whereas in atrial fibrillation, we have the absent A waves. And in patients with atrial septal defect, which almost acts like tricuspid regurgitation because it's continuous flow into the right atrium through the atrial septal defect, that causes a large V wave also. So ladies and gentlemen, this is a quick overview of jugular venous pulse, waveforms, and pressure. This has been a presentation of Triple N Media. On our YouTube channel, we have more than 200 lectures. So please do watch them and please do subscribe to our YouTube channel. You can get a copy of my cardiology rotations manual by sending me an email to drniknikam@gmail.com. Cardiology Seminars is a presentation of Triple N Media. Thank you so much, and please do subscribe to our YouTube channel. I will see you in the next video.